get started here, and I'll kind of pick up where we left off. So, question, Robert, how do outcomes compare between chronic lower back pain treated with yoga versus standard medical care?
I would assume yoga is better than standard medical care.
You're getting brainwashed here. Okay. So this is from the journal Spine in 2009. And it says yoga is significantly better than standard medical care in patients with greater than 3 months of back pain and 6 months of treatment in terms of both functional disability, pain intensity, and depression. And yoga significantly decreased the need for pain medication. But there's a caveat here. I haven't done a study, but I know personal experience with myself and several people I know well. If you do have spondylolisthesis and may be unstable, a lot of the stretching activities by yoga can actually cause increased pinching of the nerves and increased symptoms. So you still have to think about it and think about what yoga does and what the pathology is. If it's just degenerative disc disease and you got a stable spine, then it's probably good. Okay.
How do outcomes compare with in chronic lower back pain treated with exercise versus surgery? Again, maybe they do better with exercise.
So these are just the few outcome studies that are available. And so this just shows that 2 years out, there's really no difference in 349 randomized patients with chronic low back pain. Now, this is chronic. This isn't people who come in with acute, no onset, never before back pain. There, I think you really have to look. You have to look and hope it's a disc extrusion. If it's a disc extrusion, see where it is, see whether that's the cause of the symptoms, and then have to decide whether you do surgery or we can control the pain with medications and let it resorb itself. If it's anything else, then surgery is not all that valuable anyway, so you might want to do it. So they had 160 volunteers randomized to Tai Chi versus standard medical groups. After 10 weeks, the Tai Chi group had significant decrease in pain and disability compared to the standard medical group. And this is another study by Hall and Arthritis Care and Research. I don't know. I think we talked about this study, but this is one of the better studies in the literature from New England Journal of Medicine from 2007, where they took patients who had between 6 and 12 weeks of incapacitating radiculopathy, not back pain, but radiculopathy. Radiculopathy has been considered for a long time something that's best treated by, or an area where surgery is more likely to be beneficial than if it's just back pain. And then they did MRI, and with the MRI showed a herniation and 283. Then they randomized them between surgery and no surgery. And they found that surgery, you got faster pain relief. Typically, the pain was relieved right after surgery, the radiculopathy. But if you looked at 1 year, there's really no difference in the outcomes between the two groups. So this is the main basis for saying that if you can control the pain by medications, then you may be better to wait and not do surgery. And this also fits in with Mike Modick's early papers from the end of the 1980s, which he showed the best prognosis of all were in people who had acute disc herniations because they all got better. And we've actually had several fellows over the years who developed severe pain, and the MR scan showed acute disc herniations. And guess what? They all elected to treat them medically, and within 2 months, the symptoms had almost completely resolved in all of them. So, anecdotal information, but there is some better scientific studies to corroborate that. Okay, so what are the results of published randomized controlled clinical trials compared to surgical and non-surgical treatment?
I would say surgical is not superior.
This is Anderson and al. From the Journal of the American Academy of Orthopedic Surgery, 2008. So they looked at 5 randomized control trials published between 1983 and 2007, over 1,000 patients. And unfortunately, there was a lot of crossover from the randomized groups because it was thought to be not ethical to not allow people to have surgery if they really wanted it. And therefore, the outcome of these studies was really significantly compromised, and it really wasn't able to give a definitive answer. Okay, so let's go on. Here's a study that looked at when you look at bone fusions, what are the criteria for seeing if there is stability of the bony bridging. If you have flexion extension views, you should have less than 3 degrees of motion between flexion and extension. You should have no lucency around the implant, minimum disc height lost at the implant, no fractures, no sclerosis, and you need to see visible bone formation between the two. And that can be subtle sometimes even with CT, but subtle increased density showing ossification between the two is sufficient. So those are the 6 things you kind of look for. This one primarily on plain films, and the other are best evaluated by CT.
I had a patient with 5 surgeries and 4 fusions, and it was very difficult to determine whether there was any complete healing.
Yeah, especially if you're severely osteoporotic.
Yes, it's very difficult to figure that out sometimes.
Yep.
After multiple operations.
Yeah. So we'll come back again to Modic findings. There's the end plate disease, initially published in 1988 by Mike Modic and his group. So type 1, as you know, is decrease on T1, increase on T2, which is acute edema within the end plate. Type 2 is increase on T1, isointense on T2, that's fat. This is edema, and this is subacute disease, and these occur in chronological order. So initially you'll see acute changes that will heal to the subacute changes, and then chronically you get decreased signal on both T1 and T2, and that's because the fat is replaced by hypertrophied trabecular bone in that area. So this is a study from 2009 showing type 1 changes are associated with increased adjacent degenerative disc disease and discovertebral bodies. So this is associated with degenerative disc disease. Back pain in the presence of type 1 changes are associated with growth of anaerobic bacteria. This was in 2 studies in the European Spine Journal. So they were saying that these were actually infections. The problem with this is that by MR scan, it doesn't really show a lot of edema within the disc. None of these that I'm aware of have ever gone on. Well, I'll say none of them. I'm sure there are a few around that are actually true infections, but none that I've ever seen over the 40 years that I've been looking at this have actually gone on to frank abscess formation and osteomyelitis that's ever been proven by culture. So this was something that was popular in 2013 that I don't think has been really reproduced by other people. So I think it's rarely due to infection.
Well, I frankly think that that's a silly
Okay.
kind of silly to talk about infections and that kind of a situation.
Yeah. So
We get infections for various different reasons, urinary tract, etc. So to come out and say what they did there
well,
on the Modic
they stuck needles in and did cultures.
and Modic changes are in 100% of people after the age of 50. So I mean,
Yeah.
give me a break.
So there's a type 1. That's a little bit more of a type 2 where you see fat replacement. Here we have low signal on T1, high signal intensity on the stir. Here we can see fat within it and down at this level. So different stages of motor disease in the same patient. Here we can see on 11102, low signal intensity on T1, high on T2, type 1. If you follow it over time to a year and a half later, what you can see is that this goes on to loss of the high signal intensity on the T2, more lower signal intensity. So it went from a 1 to a 2, and it went from low signal intensity on T1 to high signal intensity. So this is fat replacement in the area. So it just shows extending from type 1 to type 2 in the normal process. End plate changes, according to this paper in 2006, it's rarely do you have discogenic pain without end plate changes, but you very commonly will have no pain in patients with end plate changes. And there are other ways to describe different end plate changes, but I don't think we need to go through this. This is what it looks like on CT and on the gross specimen. Here you can see all these hibernation, decreased density here, and you can see the trabecular bone with holes in it. Here we can see almost all the cartilage is destroyed except for little tiny pockets here, marked joint space narrowing, and some subchondral thickening. Here's a case where you actually have an impaction of the superior end plate, and there you can see the fracture histologically. These are all cadaver studies. The MR scan, and that's what the histology shows, showing the superior end plate fracture with depression. Okay, Robert, does MRI measurement of subcutaneous fat thickness predict severity of intervertebral disc degeneration and modic end plate changes?
I would say yes.
Okay, it significantly correlates with intervertebral disc degeneration and modic changes in men, and this is looking at a greater than 1 centimeter thickness of the subcutaneous fat. You'll find that in our patients, it'll be rare for you to find someone who is a centimeter or less. However, what they found is that if you actually look at body mass index, there was not a good correlation. And there's several studies that show that subcutaneous fat thickness may be better than actually BMI. And other people have actually looked at retroperitoneal fat, which may be even more significant than subcutaneous thickening. But there certainly is growing evidence of that obesity has a role to play in many diseases. I'll have a talk about that later, even though it's not PC to talk about that in this day and age. Okay, what do you think's going on here?
68-year-old female, tender posterior mass.
So Ilior, it's here's the skin marker back here.
Okay. So posteriorly at the level of L2-3, there's edema between the spinous processes extending to the soft tissues posteriorly.
Okay. And what are these?
The spinous processes.
Okay.
There's
And what's going on here and here?
Yeah, maybe
There.
there's some irregular dark tissue. Maybe there's an injury of the interspinous ligaments.
Okay, so what would you say if you saw this in the femoral condyle at the knee, and this is the tibial plateau?
Some degenerative change, subchondral cysts.
Yeah. So there we can see this, and this is called Bastrup's disease, and it's really degenerative disease where instead of having nice separation between the spinous processes, what you get degenerative disc disease. The disc collapses, therefore one vertebral body and posterior elements get closer to the other one because you no longer have the disc spacer there. That can lead to direct bone-on-bone articulation between the spinous processes and develop a degenerative disease. Then you can get these fluid formation and degeneration, which is really a kind of a bursitis between the two. This can become very painful, and you get masses, both soft tissue as well as fluid masses posteriorly here. And this really comes under the name of Bastrup's disease, and it can be a cause of pain. And there's specific treatment for these. Sometimes you can put spacers just between the spinous processes in this sometimes. And here where we have, I think this is a new patient. Yeah, this is a different patient. So what do you think's going on here? Someone with back pain.
All right, looks like we have a focus of radiotracer uptake in the left lower cervical spine and kind of diffusely in the L4 vertebral body.
Yeah. So it looks like it's kind of in the vertebral body. If we get an MR scan, it's actually but between the spinous processes here. So this is again severe degenerative disease and someone with Bastrup's disease. So it's common in elderly patients with degenerative spine disease. I think you really have to have degenerative disc disease to get this. I don't think you really get it without it. Though remember that sclerosis on the CT is often not symptomatic, according to this paper.
All right.
Any history on these folks?
I don't have any on those right now, John, no.
Okay, so we have axial images of the L spine, both T1 pre and T2 pre. I just see some facet arthropathy kind of bilaterally. Post images, looks like there's enhancement of the facets more so on the right.
And this is just typical degenerative facet disease. So, and it needs to be commented on. So from 3, 4 on down, I try to always comment, even if it's normal, then I say it's normal. And this is very common from 3, 4, 4, 5, and 5, 1. Okay.
That yellow ligament is also thick.
Yeah. Yeah. So so the ligament inflavum here, generally with these, and it depends on who you talk to, a lot of people call it hypertrophy of the ligament inflavum. But most of the neurosurgeons I know say that what happens is that you don't really thicken usually the ligament inflavum. What happens is when you get decreased space between the two levels, you get settling of the two and you get buckling of the ligament inflavum rather than true hypertrophy. But I think there's some debate on that matter.
Okay, so looking at the facets on the left facet joint, I see some increased signal there. This is a T1.
T1.
So right on T1, I mean, could it be blood?
Okay, could be blood. What else could it be?
It could be fat. Fat. It's sats out, so it could be.
Yeah. So this is called a lumbar facet fat pad. They're not very common, but you can get fat inside the joint space also. And here's a discussion of it in neuroradiology called facet fat pads. And I'm not even sure whether they're symptomatic or not, but when you see it, I just comment on it. But they're pretty rare. Okay, what do you think here?
All right, so looking at these sagittal cuts of the lower lumbar spine at L4-5, we have severe canal narrowing. Just based on that appearance, I think it's secondary to some some facet joint cysts, right?
Okay, yeah, and so we've seen some of these before, but just to kind of complete the facet disease. And according to this study in skeletal radiology, 50% of these, or greater than 50%, will get better by percutaneously rupturing the cyst. And so that's kind of the schematic diagram of what happens. Okay, and here's another facet cyst coming out here on a low field scanner, producing pretty severe central stenosis. Most of these that I've seen have actually been treated by surgery rather than percutaneous. But percutaneous.
have a tendency to come back.
Yeah. And then here just some more. You can have them kind of going more into the midline too, so they can migrate a little bit here. Okay, Robert.
We have a 76-year-old female, sagittal and axials. Looks like there's another cystic structure in the posterior spinal canal.
Yeah, producing significant central stenosis. Same patient. And this was, I think they went to surgery and they called this a cyst coming from the ligamentum flavum. Okay. Elior.
Okay, so looking at the right facet, we see is kind of this rounded structure that's T1 bright and T2 dark.
Right.
So
A lot of degenerative facet disease here too. Yeah.
mhm. Yeah, I wonder. I mean, could it be hemorrhagic? Could it be maybe calcified? The rim
Okay.
is dark as well, so maybe
So,
chronic.
On MR, this was called a synovial cyst. Clinically, they thought this patient was going to have a schwannoma. Here's what the CT looks
It's got, would you say there's protein in that cyst or something?
Yeah,
It's
well,
not clear fluid.
it's not clear what it's definitely, it doesn't look like fluid on the T2. It is somewhat bright on the
Yeah,
T1. There's several things that could be bright on the T1.
kind of mix of something.
Yeah. It doesn't look like fat though, and it doesn't look like fluid. Okay, here's what the CT looked like.
CT means similar thing. I'm not sure. It's not calcified,
Okay,
but
here it is.
yeah, I'm not sure it's helping too much.
Okay, so after the CT, they were concerned about it being a sequestered disc. And so they went to surgery and removed it, and it was just a chronic area of inflammatory disease. So basically, granulation tissue, scar tissue. Okay, and then we looked at some of these between the upright and different positioning. Here we can see in the upright that's sitting in this location. And when they went to upright, I think I showed this one the other day, it got a little bit bigger and more rounded. So when you put pressure on the posterior elements, it increases the pressure within the facet joint, forces the fluid out into the cyst, and it becomes more prominent. And then here we can see, here's flexion, here's extension. So as you extend, you put more pressure on the posterior elements, increases the pressure here, forces the fluid from here out into the cyst, which we can see going to the neurocanal. So these are somewhat positional dependent in terms of the size.
What I have done is on patients with intermittent symptoms is to have them exercise before they had the MRI done.
Oh, good.
And that I found to be very helpful.
And get them good in symptomatics. Okay.
So we have a 61-year-old.
Well, if they're extremely
10 years after
symptomatic,
surgery.
then obviously you cannot do that.
Yeah, right. That's a good point, John. Okay, so what do you think here?
All right, so it looks like there is a defect in the left, on the left side, like a partial laminectomy. And there's herniation of that fecal sac into the surgical defect.
Yeah, so it looks like there's CSF coming back out
Yeah.
into here, maybe over there. So this was a meningocele, which is actually communicating with the facet joint.
In my experience in many different joints, whenever you have a cyst, unless you do a complete excision, and I mean complete, and not leave any degenerative uh, disease behind, you're going to have a recurrence,
Yeah,
especially in the wrist.
that
Uh,
makes
uh,
sense.
uh,
So here you can see another facet cyst here, and you can see it compressing that transiting nerve root, which is a little hypertrophied here. So you can see that these can be symptomatic and compress the nerve root. So these can present with radiculopathy. Okay, Robert?
Okay, so we have axials. It's like a T1 and T2. Looks like there's prominent facet arthropathy, and then it's kind of a cystic structure there.
So this we can see is really within the palm. You can see it at multiple areas, and these are subchondral cysts, and they're typical from degenerative disease, just like we see in the other joints. Okay, let's talk a little bit about foraminal stenosis. We've already seen how the nerve roots come out kind of through the intervertebral canal here, facet joints, and they should be surrounded by fat when they come out. So this is a grading system from 2010 from Lee et al., where they looked at the sagittal T1 weighted MRs. In normal, you could see the nerve root within the foramen here with fat surrounding it, some little vessels there. And it should be that way at all levels. So that's normal, and you can see fat going all the way around the nerve root. Then they described several different kinds of foraminal stenosis. One is where you lose the fat anteriorly and posteriorly, but you still see a little bit superiorly and inferiorly. That's kind of the situation here. A little bit of fat up here, a little bit below, but it's compressed. Where you don't see it anterior and posteriorly, that's grade 1. You can also have grade 1 where you don't see the fat superiorly and inferiorly due to disc protrusion, but you can anteriorly and posteriorly. And then there's grade 2, where you basically lose the fat in 3 or more quadrants around the nerve root, but the nerve root is still relatively round. That's grade 2. And then grade 3, you lose the fat, but you have deformity in the nerve root. And according to their data, it's grade 3, which are the symptomatic patients. So you really need deformity of the nerve root before MRI correlates well with radiculopathy.
I don't think you use that system, do you, John?
I think about it when I read a study, but I do not use grades 1, 2, and 3. I describe it because I think most people aren't familiar with that grading system. So I think it's best to describe it. And so I'm most concerned if I lose all the fat around it and I see deformity of the nerve root. So here's a case with foraminal stenosis. Now, and then most people typically say it's mild, moderate, or severe. Or a mild, you would see a little bit of loss of the fat, but you still have mostly fat all the way around it. Moderate is where you lose the fat, at least 2 different areas. And severe would be where you lose the fat all the way around, especially if you can see some deformity of the nerve root. But often in situations like this, we don't really get a great view of the nerve root in order to see whether it's deformed or not. But here we can see foraminal stenosis. Clearly, the 4 level is different from the 3 and 5, so this is clearly foraminal stenosis. Then in 2004, Fearman came along with basically the same grading system in this particular paper that came out before, which we see here.
Anything to put in the literature.
Right, right. So let's see, who's next? Jason? Okay.
College stuff.
Okay. What MRI findings correlate to positive response to steroid injection?
Motic type 1?
So according to this paper, it's disc protrusions plus having a sequestration, degeneration by osteophytes, grade 3 root compression, and foraminal and extraforaminal disc herniations. So that's what they said in skeletal radiology. I'm not exactly sure why it would help with grade 3 root compression, because you're not improving the compression by putting steroids in. Maybe you could decrease some inflammation that you might have. And again, the actual steroid itself might suppress some of the symptoms, but it's really not going to treat the underlying cause of the problem. So I've always been a little skeptical of this particular paper, but this is what they recommend. Okay. 60-year-old male with increasing chronic back pain.
All right, so we have, these are all CTs. Looks like we have severe facet arthropathy, right greater than left.
Okay. And you can see it really on all the sequences here at the L4-5 and L5S1 levels, which you can see there. So now the question is, you've got a lot of degenerative disc disease here. What's actually causing the patient's symptoms? Do you inject everything with lidocaine to try to find out? Do you inject everything with steroids? So one thing that people have looked at is doing PET scanning. Bone scanning, you don't get a high enough resolution to be able to localize it. And it turned out that the area of symptoms, the area of abnormal PET bone scan was this area, and that's the area that they treated and the patient got better. Most people will know no insurance companies are going to pay for a PET scan for back pain, but you can keep in the back of your mind that if you have someone who's willing to pay for it, that this might be a way to determine where the clinical symptoms are coming from.
I'm not sure if an examination clinically wouldn't give you some idea which side this was. I think I could find this clinically.
Good. Okay. Okay, let's go and talk about central stenosis. So here's a normal canal, and when spinal stenosis, you can get typically you can get it from disc protrusions, obviously. You can also get it mostly from degenerative disease, primarily involving the facet joints, primarily with hypertrophic bone formation, and then you can get the thickening or redundancy of the ligamentum flavum there. So, Robert, what do you think about this case?
Yeah, so we have a sagittal and axial. Looks like there's a disc herniation almost. Yeah, pretty severe stenosis.
So this is kind of central stenosis.
What's a severe herniation?
So this is central stenosis. So we actually probably have central stenosis at 3 levels here. In this case, we have a focal extrusion at the 4-5 level. John, what was your question?
What's a severe herniation?
Okay. So Robert, what's a severe herniation?
Something that results in severe stenosis.
Well, I think what you're talking about is an extrusion of a disc.
Yeah. Yeah. So, I don't think people can use the term severe herniation. I think that that's really not part of the standard nomenclature, but you do talk about, focal protrusions, extrusions, and then you talk about the how severely they either narrow the canal or whether they compress or displace nerve roots.
Well, you can tell that to the patient, of course.
Right. Yeah. So this has also been looked at, like everything else. There are grading systems, and here is one published grading system. This is in Skeletal Radiology in 2018. Normally, you should have layering of the nerve roots in the cauda equina posteriorly. If you don't have a nice flat layering, then that may be early abnormalities. Here we can see it's layering okay, but you're decreasing the amount of CSF around it. You should have really an abundant CSF. Here you have narrowing both anteriorly and posteriorly, and then when you get to the point where you really see crowding of the nerve roots, that's level 4B, and where you see no CSF at all, that's level C, and then D is where the entire canal is really low in signal intensity. So basically, I think the most important thing is the amount of CSF surrounding the nerve roots in the cauda equina as an indication for the severity of the stenosis. So severe stenosis is where you see no CSF surrounding the nerve roots in the cauda equina. You can also have severe stenosis, but intact posterior fat pad. That can still be symptomatic severe stenosis. And then moderate central stenosis, I think you can see fluid between the different roots, and then the normal is up here where you see plentiful CSF. This just shows some foraminal stenosis. Okay. Let's see, who's next?
Me.
Okay.
Axial views of the spine, I see, well, if we're looking at the disc, I would call this a disc bulge. I mean, it's involving more than 180 degrees, I think.
Well, you can't really tell on this image
Okay.
because you can't see the margins of the bones. This is just an axial right through the disc.
Uh-huh.
So you'd really need to also look at the sagittals. Now you could say the disc might be abnormally flattened, but at the 4 or 5 level, the normal disc can often be very flat.
Mm.
What here we're looking at 2 different times. So 2.5 years later, what differences do you see between this study and this study?
I see crowding of the cauda equina.
Yeah, so here you can see actually some CSF above the nerve roots. It's less than what should be normal.
Mhm.
So they probably do have some disc bulge here and a kind of moderate central stenosis. But at this point, we don't see any fluid there. This is all fat. So this is more severe central stenosis. And the other thing is notice that you have a significant increase in atrophy of the muscles between the two. So you've got really progressive disease here, and the patient was more symptomatic.
And the psoas on the left is really quite interesting.
Yeah.
All right, increasing back pain post-surgery. So the 2003 to 2008. Let me see. Are we at the same level?
Yeah.
So did they remove the spinous process?
Yeah. So they remove the spinous process here.
I mean, the spinal canal looks larger on our.
Okay, because
Also,
they did a decompression here. The spinal canal is larger, but notice you have significant atrophy that's developed in the multifidus muscles bilaterally here after surgery. Okay. This just shows, again, we've seen it before, hypertrophic muscle and severely atrophic muscle. So we've already talked about that. Okay, so kind of crummy. Give me the answer here. So Robert, is there an association between sarcopenia and hip fractures?
Yes, there should be.
Yeah, so sarcopenia, there are a lot of things associated with fat replacement and atrophy of muscles. And when you get atrophy and fat replacement in muscles, very common in older individuals, when you do that, there are a number of reasons why there's an increased risk for hip fractures. One is they become very weak muscles. If they stumble, it's easy to tear the muscle, which produces pain. Then they collapse, and at the time of they collapse, they actually develop the hip fracture. Also, people just tend to lose balance. Older people who have sarcopenia are at much increased risk for just falling in general, and you can have a lot of problems with falling and so forth. So, sarcopenia has a very negative is a very negative prognostic factor in people, especially elderly individuals, and it's independent of osteoporosis here. So it becomes important, I believe, when people get older, that they actually have exercise programs to try to maintain the integrity of the muscles and the strength of the muscles. And there are many papers that have shown that that decreases the risk of falling, and the risk of falling is a major cause of hospitalization in elderly people, and it's and a lot of hospitalization after fractures ends up in the patient not leaving the hospital alive. Oh, okay. So in the past, we talked about degenerative disc disease. What else can we look at? Well, one is I talked about we can actually use MR to look at the biochemistry of the disc. So let's talk a little bit about the biochemistry of the abnormal disc. So degenerative disc, you see biochemical changes. You decrease proteoglycan. We'll talk a lot about this when we talk about cartilage disease, and you get increased matrix catabolism. Painful discs tends to be associated with hypoxia, increased cytokine production, neovascularization, and neoinnervation, done by a number of different studies that have looked at that. And some people have shown that these changes can be reversible by gene therapy. This is from the Hospital of Special Surgery in New York. So we won't go through a lot of the changes here, but lactate is a measure of anaerobic metabolism, showing decreased oxygen, poor nutrients. You then get death of the chondrocytes within the disc, and that leads to the degenerative process. And the big problem, as we talked about here, is that the nutrition all comes from diffusion from the small arterioles and the end plates. If you have end plate disease, that leads to poor vascularity here. With poor vascularity, you're going to have fewer nutrients supplied. If you sit all day long, the diffusion is very slow, even if you have normal end plates and normal vessels. You have to get up and use the pumping mechanism of compression and extension in order to decrease the diffusion of these nutrients into the center of the nucleus pulposus. So one thing that we've done is, I say we, I haven't done most of these particular studies, though I've been involved with some of them. I was involved with, there is one commercial company right now out there who has a technique to be able to do this with MR, and they've worked, I think we were really one of their first clinical sites was RadNet 20 years ago when I first started working with them. So what you can see, okay, so does anybody know what spectrum and MR spectrum is? So this is basically, if you put in radio frequency pulse at different frequencies, this shows you the amount of energy that the sample takes out of the signal at different frequencies. Now, what's happening here? What's happening? Well, heck, I was wanting to finish the lecture today, but let me go through and do this detail. So if you have an atom like a hydrogen atom, you have a nucleus that's one proton, and you have one electron with it. Now, that's compared to a biological macromolecule, where the molecule itself may have hundreds or even thousands of electrons with it. If it's a complex molecule with many different elements, especially if elements of iron or higher, larger nuclei that have many, many electrons. If you take a big macromolecule and you put it into a magnet, what happens is that the orbits of the electrons will change. They'll change in a way that will actually decrease the magnetic field inside the electron cloud. And if it's a complex molecule, the changes in the orbits of the electrons will be relatively complex, and the actual exact magnetic field at the level of the different nuclei within the molecule will be slightly different. Now, if you put in a RF pulse and do an NMR experiment for a hydrogen atom that's within one of these molecules, what will happen is its nucleus will resonate at the exact Lumbar frequency based upon the exact magnetic field it's in, which means that some protons will resonate at higher radio frequency signals and others at lower. So what you get if you span the entire range is you'll find in this particular case there are a lot of hydrogen nuclei or protons which are at this particular frequency because they resonate. When they resonate, they take energy out of the RF pulse. Somewhat less here and a few all the way along here. So what happens is each of the complex macromolecules will have a different fingerprint in terms of where it absorbs the RF signal. So then if you put in a spectrum where you look at signal absorbed per frequency, you'll get something that looks like this. And it turns out that a lot of the protons within the atoms, within proteoglycans, resonate right about this frequency due to the shielding that they have from the surrounding electron cloud. And lactate, actually the bulk of the protons actually resonate at a different frequency. So this tells you how much proteoglycan you have in a sample. This tells you how much lactate. And in the normal disk, you should have less lactate than proteoglycan. If this signal switches, what you have here is less proteoglycan and much more lactate. This is the signature of anaerobic metabolism because you now have much more lactate than you need. And therefore, by using MR to measure the concentrations of different important biochemical elements within a disk, you can non-invasively basically do an evaluation of the anaerobic metabolism. Now, when you do this, and this was a study before I got involved with them, I think this was done at UCSF, what they found is if you took painful patients and non-painful discs, and discs in people who do not have pain, what you'll find is you have very high proteoglycan peaks in those who don't have symptoms, and you get very low proteoglycan peaks, or put it another way, you have low lactate, a lower ratio of lactate in non-painful disc and a high ratio of lactate in painful disc. And you got an almost complete separation between the symptomatic and asymptomatic groups. So this is really a biochemical analysis that can be done non-invasively that this study suggested was an accurate way to differentiate painful from non-painful discs. And so we and others a number of years ago tried to push this as a replacement for discography and evaluating for painful discs. And other studies were done. On MR, they all look pretty similar. A little bit of low signal intensity, maybe at 5.1, but we can see we have normal high proteoglycan, normal low lactate at these two levels, and it reverses at this level. And this is where, and then this was a study where we correlated the MR spectroscopy with discography, and we found there was almost perfect correlation between a positive discogram and an increased lactate peak. And this is the study here. We really found that there was actually one outlier that didn't fit in here, but there's, from a statistical standpoint, there was a remarkably clean separation between painful and non-painful discs. So we kind of pushed this down. The problem with this is that nowadays nobody believes that you should do a fusion for a painful disc. That was what was thought early on when this was started in around 2000. But because of the complications with doing discectomies now, and therefore the concern is now, okay, so we find out what's the painful disc, what's early degeneration, so what? What do you do about it if you're not going to operate? And again, most of the decisions as to do MR or not have to do with whether the hospital and the physician can increase their revenue by using it. And so since determining the level of the painful disc is now no longer considered a way to determine surgery, there is less of an interest in it. Though what hopefully we'd like to see is people would use that information and start developing non-surgical interventions that might be able to help protect discs and reverse the process, or at least stop the process from progression. Let's see. Tayson, what do you think of this?
All right, looks like at L5S1 we have a disc extrusion.
Okay, let's spondylolisthesis disc here, a little bit
Well,
up here,
yeah.
2, 3. So what are we? Here's a disc here.
I think there's no central canal stenosis.
Okay. So this patient had back pain. It could be due to these discs, but it actually turned out to be due to the patient's lymphoma.
Oh, yeah.
So this is just to remind you, at the end of every study, make sure you look at the retroperitoneum. I've only had a few cases of retroperitoneal lymphoma, but the first one I missed. More importantly, you should look at the kidneys, because it's more likely that you're going to have a kidney stone. And obviously the aorta and aneurysms, which we already looked at yesterday. Okay.
So we have a 17-year-old male with acute back pain. Looks like there may be a small disc protrusion, L5S1, but otherwise looks relatively okay.
This is probably going to be normal. You normally have a little bit of bulge here. A lot of people like to overcall these.
Why is this canal not taper?
What?
Is it supposed to taper off a little bit?
The canal is supposed to be down here.
Yeah.
Patient probably has a little congenital variation down here, but that's very variable. Look at the axial images here.
Yeah,
So the patient had right-sided pain.
gotcha. Maybe some mild right hydronephrosis.
Patient had a ureter, and this patient had a stone. Let me see. Okay, here's a 82-year-old with acute left back pain. Here we can see a lot of degenerative disease here. Here we can see severe central stenosis in this particular patient. But if you look here, the kidney, you've got hydronephrosis on the left side. If you follow this down, you can actually see that this patient had a lot of stones within the left kidney. And as you follow it down, there's actually a stone at the lower end of a dilated ureter. So they had terrible back disease, but the cause of the patient's symptoms, again, was a stone. So just remember.
Usually though, in urethral stones, the pain is on the side.
Right.
And doesn't go down the leg.
Okay, and so here we have back pain again. Here the MR scan. Here we see another case of hydronephrosis, and there's the stone and the ureter. Okay.
How long does it take for proteoglycans to go from the end plate to the center of the disc? Fellows?
Proteoglycans don't move.
They don't move?
No,
Well, what
the
nourishes the disc?
oh, the nutrients diffused. Yeah, I think we talked about that the other lecture. I kind of need to get through this lecture, John, before our time's up. Is that okay?
Okay,
I think
I'll
we
shut
talked
up.
about that being a couple of hours before.
Mhm.
Elio, are you next?
Yes. Pregnant pain with back pain, or a pregnant patient with back pain. Looking at the left retroperitoneum, um, yeah, what's going on there? Is that a hydronephrosis? Could that be a ureter?
Yeah, this was an
Yeah.
iliac vein thrombosis. See,
All right, hip and knee pain, rule out fracture or stenosis. I mean, it looks like there's depression at the L3 end plate,
okay, maybe
and
here.
yeah, maybe there.
This
This looks like yeah, some biconcave deformities.
What?
No, just some biconcave like depression of multiple levels. Does the aorta look a little big? Oh yeah. We have a dissection.
Yeah, so there's a dissection goes all the way into the iliac. Yeah. Let's see. So here's actually a paper where they looked at extraspinal findings in people with back pain. Kidney cysts are the most common, but you can see a lot of other renal anomalies. Adrenal masses are quite common, though often we don't get high enough up to see the adrenals. And then uterine problems, ovarian cysts, but most of those are going to be normal. And then retro or aortic renal vein things. So the question is, why use MRI in the lumbar spine if it looks like a lot of these changes aren't relevant? So looking at degenerative disease, it's thought to be useful to map out structural changes before surgery, to exclude non-structural changes before surgery so you don't operate on something you can't operate on, and to evaluate non-disc disease in high-risk patients. Other study, this is a famous one from Bowden and JBJS in 1996. Acute back pain, we recommended no imaging in the first 6 weeks because the vast majority will resolve. And at that time, people thought, well, the problem was the MRI is very expensive. But what really the problem is if you image too early before the pain goes away, you're going to see abnormalities. And in those days, it led to a lot of unnecessary operations. And that's what the expense is. The expense isn't the MR, it's the unnecessary operations. Unless you have progressive neurologic findings, the known malignancy, constitutional symptoms, basically if you think they have an infection or acute trauma. Chronic back pain, you can do an MRI. And then here, acute radiculopathy, no imaging in the first 6 weeks, unless, again, you have progressive neurologic findings, loss of bowel and bladder, trauma, malignancy, or infection. This is from the American College of Rheumatology. And if you have unexplained weight loss, recent significant trauma, fever, immunosuppression, history of cancer, and duration greater than 6 weeks. American College of Physicians, again, they say routine imaging leads to unnecessary interventions and cost. If you have severe or progressive neurologic deficits, suspect infection, cancer, or severe trauma, and repeat imaging should be based on new or worsening symptoms. So the conclusion then is renew that gym membership now, strengthen the core muscles first, and keep the BMI under 25. Thanks. John, we have a minute or two. Did you want to ask your question?
Yeah, from proteoglycans, nourishment to the center of the disc. How long does it take
Guess
from the end plates?
several hours.
A year. 1 year. And that's why we have real problems with the back in many ways.
Where did you get that, John? I'm not familiar with proteoglycans.
I was reading it in the Campbell's.
Oh. Oh, interesting. Okay, thank you.
Yeah, it's a degenerative disease. It's bad news. The disc doesn't get nourishment because it's it's a very non-vascular structure.
Yep, that's right. It's all diffusion.
And so how does it diffuses into the disc. It doesn't go by a vessel.
Right.
So it's
Exactly.
it's a diffusion process. The other thing that we haven't considered is there are genetic markers now that are we're picking up in terms of why people have back